Welcome to The Explainer. Today, we're diving headfirst into what is honestly a fascinating medical mystery, veterinary iron deficiency anemia. We're going to take what might look like dry clinical data and turn it into a full-blown diagnostic investigation. By the end of this, you'll see exactly how a few subtle clues in a blood sample can unfold into a complete, life-saving clinical pathway.
Let's jump right into our investigation with the single most important question you can ask. How do you prove your patient is truly out of iron? Here's the thing. A low blood count is really just the beginning of the mystery. Anemia is a symptom, not a final diagnosis. So we need to figure out exactly how to prove what's actually causing that specific drop in red blood cells.
Okay, let's set the stage by defining our primary suspect here, iron deficiency anemia, or IDA. In the veterinary world, this almost always stems from a chronic external blood leak somewhere in the patient's body. We aren't usually talking about a sudden, massive traumatic injury. No, we're looking for insidious, ongoing losses. Think along the lines of gastrointestinal parasitism, hidden ulceration, or even neoplasia, where tumors are just slowly bleeding out the body's iron stores drop by agonizing drop.
Section 1. The first clinical clues.
Like any good medical detective, we've got to start our investigation right at the scene of the crime. When we run a standard complete blood count, or CBC, we're hunting for the classic indices, microcytic and hypochromic cells. But why does this actually happen? Well, think of it this way. When iron is scarce, the red blood cell precursors are forced to work extra shifts. They literally undergo an extra division during erythropoiesis, just trying desperately to reach their optimal hemoglobin quota. The result? They come out smaller, which is what microcytic means, and paler, meaning hypochromic, with an expanded central pallor.
But here's the cool part. We don't always have to wait for those mature cells to shrink to know there's a problem brewing. Keep in mind that a drop in reticulocyte hemoglobin content, or CHR, is actually the absolute earliest automated marker of iron restriction. This is a fantastic early warning system for us, mainly because it shows up days or sometimes even weeks before the mature red blood cells actually shift in size or color.
Now, beyond the automated numbers, let's quickly review the physical evidence found right under the microscope. We're looking closely at erythrocyte fragility. You're going to see schistocytes, which are these little fragmented cells, and keratocytes, which look kind of like tiny blister cells. You'll also spot chodocytes, or target cells, which are caused by an altered surface area to volume ratio. Honestly, these malformed, fragile cells provide incredibly high-yield circumstantial evidence that the structural integrity of the blood is totally compromised.
Now here is a fascinating twist. Did you know that a massive 50% of canine IDA cases present with reactive thrombocytosis? That means they actually have an elevated platelet count. Crazy, right? Why does that happen? Well, it's likely driven by the body's concurrent inflammatory response to whatever is causing the bleeding in the first place. Plus, there's a cross-reactivity between the hormones driving red blood cell and platelet production. So counterintuitively, high platelets can actually be a massive clue for low iron.
Section 2. Confirming the iron panel.
So, while all this CBC data provides strong presumptive evidence that totally justifies a safe empirical trial of oral iron, it's still, well, circumstantial. Before we break out the heavy parenteral therapeutics, we absolutely must interrogate the true state of the patient's iron stores. Mapping this out lets us differentiate absolute deficiency from functional deficiency. Notice how serum iron is low in both scenarios? That's exactly why we can't rely on it alone. But look at serum ferritin. It's low and stores are truly depleted in absolute deficiency, but it's normal, or even high, when iron is just being sequestered away due to inflammation. We also look at TIBC and TSAT to paint the complete biochemical picture.
You do have to be super careful here, though. Here is a clinical pearl you absolutely must remember. Ferritin is the most reliable marker, yes, but it's also an acute phase reactant. This means severe concurrent inflammation can actually cause ferritin to lie to us. It falsely elevates it back into the normal range even when the patient is literally starving for iron. Because of this tricky little loophole, finding a low TSAT alongside microcytosis is often what you really need to definitively confirm the diagnosis.
Section 3. Executing iron replacement therapy.
Okay, so fixing the deficit brings us to a slightly terrifying biological oversight. Mammals completely lack a physiologic mechanism to actively excrete excess iron. You heard that right. None. Zero. Once we put iron into the body, it is stuck there. This makes our choice of therapy incredibly high stakes. We have to carefully choose between oral and parenteral therapy.
Oral therapy, usually ferrous sulfate, is our first line. It's brilliant because it exploits the intestinal mucosal block. Think of the gut as a bouncer at a club that only absorbs what the body actually needs, preventing systemic overload. Parenteral therapy, like iron sucrose, on the other hand, entirely bypasses that bouncer and forces iron directly into systemic circulation.
Because it bypasses that built-in intestinal block, parenteral iron is strictly reserved for really severe cases, or when oral iron causes severe gastrointestinal intolerance or malabsorption. The risks of getting this wrong are huge. Forcing too much iron into the system can cause hemosiderosis, which leads to massive oxidative tissue damage. Furthermore, since bacteria absolutely love to feed on free iron, flooding the system can rapidly exacerbate active bacterial infections.
Let's look at exactly how this shapes our specific treatment protocol when parenteral iron is truly needed. Look at the precision required here. Exact dilutions in 0.9% NaCl administered via a slow IV infusion. And pay close attention to the strict safety warnings. You must never, ever administer this intramuscularly or subcutaneously. Finally, because of the profound systemic effects, the patient has to be actively monitored for a full hour post-infusion just to catch any rare hypotensive events.
Section 4. Beware the babesiosis mimic.
Just when you think the case is closed and your treatment plan is totally locked in, we've got to introduce a late-stage narrative twist, the hemolytic imposter. Every good detective story has one, right? We have to make sure we aren't being completely fooled. What if the anemia we're seeing isn't caused by an external bleed leading to iron deficiency at all? Hemocortisol infections, like Babesia, cause marked, regenerative, hemolytic anemia. This means the body is actively destroying its own red blood cells at a massive rate. It creates a highly confusing diagnostic picture that can look suspiciously like an iron problem at first glance.
But notice the stark contrast when you look closely at these two profiles. Remember, true IDA is microcytic and hypochromic, small and pale. But with babesiosis, the massive red blood cell destruction triggers the bone marrow to completely panic and release huge, immature reticulocytes that are poor in hemoglobin. This makes the blood picture macrocytic and hypochromic, large and pale. That macrocytic shift, that's your dead giveaway right there. But wait a second. Why might the iron panels still look a bit messy during this mimic scenario? It's because of functional iron sequestration. In this mimic scenario, the massive systemic inflammatory response induces the production of a hormone called hepcidin. Hepcidin acts exactly like a bank vault. It deliberately locks the body's existing iron away safely inside macrophages just to keep it away from pathogens, instead of losing it entirely to the outside world.
And this is exactly what you should take away from this explainer today. Getting this wrong has massive, massive consequences. If you misread the signs and pump parenteral iron into an animal that is actively hiding its iron to fight off a massive infection, you are literally feeding the fire. So I'll leave you with this question for your next clinical case. Are you treating a true deficit, or is the body intentionally hiding its iron to survive an inflammatory attack? Always question what the body is really trying to tell you.